Welcome to our session entitled Risk and Responsibility in Healthcare. I'm really excited to have two of our physician researchers and folks who really have, I think, taken the national landscape by storm in some cases. Really, we're representing what I would say is dramatically different continuums of researchers who are looking at the most appropriate uses of AI systems. And I just want to remind folks that there's a framework. When they're talking about the research that they're doing, please keep in the back of your minds what type of AI systems are they talking about. Not all AI systems are the same. What are their conditions of deployment? What are the levels of oversight? And be sure to ask them those questions so that you have a better understanding. Those questions are important because they define vectors of risk. So levels of autonomy is important. Conditions of deployment can also affect your risk. When you think about functionality, that can also affect risk. And certainly methods can affect the level of risk. And so I want you to start thinking within that framework because there can be conditions of deployment that are relatively lower risk, although they may use more higher risk methods or systems or levels of autonomy. And we'll practice that some more during lunch and at the end of the day. So I'd first like to welcome Dr. Chandra, the Chief Telehealth Officer at the University of Mississippi Medical Center. He hails from one of the telehealth centers of excellence, only one of two in the nation. Dr. Chandra has an illustrious career in his practice. He's led major telehealth and digital health initiatives across the country, from Northwell Health's COVID response in New York to the University Medical Center in Mississippi Center for Telehealth. In addition to being a practicing intensivist and strategic telehealth leader, he recently added an MBA to his credentials. When he's not out trailblazing virtual care, he's learning and living the culture of the Deep South. Next to him is Dr. Ethan Goh, who's the executive director of Stanford's ARISE network, where he leads multi-center evaluations of large language models in healthcare. He's a physician scientist with publications in Nature Medicine and JAMA. He's also the associate editor for BMG Digital Health and AI. So if you want to get published, he might be a good person to talk to. So these two gentlemen represent, I think, the best of the profession in terms of the North Star in transformation and innovation. So with that, I'm going to hand it over to our first presenter.
Right, so great to be here learning with everyone today. I'm really excited about some of the upcoming talks. So my presentation today is going to be about the research coming out of ARISE. Briefly about myself, my name is Ethan Goh. I'm a physician scientist. I'm based primarily at Stanford within a research group. It's a very traditional setup. What it really means is that we do research, we apply for grants, and then we use the money to do more research. But as you can see through the earlier presentations, it's been a particularly exciting time. And I think because we sit within Stanford Healthcare, and most of the researchers in our group are like myself, physician scientists, clinical informaticists, or software engineers, we have obviously more of a focus on physician-facing tools primarily, meaning to say that we skew more towards a translational side along the type of studies and prototypes we're building. What ARISE is briefly is back in 2022, we were running a series of RCTs across different sites, primarily anchored at Stanford and Beth Israel. But we were really interested about how doctors using AI tools would perform on some of these more robust measures. And I think, as Sylvia kindly mentioned, I also sit on the BMJ AI editorial board. So if anyone has interesting submissions, please consider submitting. And on the other side, that just means that I have the privilege of actually seeing a lot of interesting, almost frontier up-and-coming technologies. If you want to learn more about our ARISE's interest, that's the QR code, or you can head over to our website. All right, let's dive right into it. Okay, so hands up, how many of you saw some of this really interesting headlines across the past 6 months? Can I get a show of hands? How many of you saw this quite interesting headlines, right? Claiming things like, oh, New York Times AI chatbots defeated doctors at diagnosing illness. And then I think just last month, Microsoft, to a lot of fanfare, right? I think even on social media, Instagram, a lot was saying, oh, its new AI system diagnosed patients 4 times more accurately. What does that even mean, right? How do you do 4 times more accurate? So I think I wanted to anchor, the direction of this presentation to put into these questions. So if you look at those headlines, right, as you can see, I think even on Instagram, they're trying to transform this into all these quite intriguing headlines. I think a few questions would come to mind, right? One is obviously, why are we even comparing doctors versus AI, right? Why are we even doing that? Whether it's research, operational, translational, why are we even thinking about this, right? And two, okay, so you say you want to compare doctors versus AI, right? I guess the next question is, how do you even compare, doctors AI in a way that actually makes sense? And in a way that robust, journals would actually publish and say it's credible. And I think the next most important question is, if these results are real, right? What are the kind of implications, for physicians, the workforce, so on and so forth. Before I get into some of these research studies and answering those questions, I just wanted to give kind of a quick 2-slide primer on how, a useful mental model of how to think about how LMs work. And what me and John Chen, who's a co-PI, he's a PI at Arise, based at Stanford, working closely with myself, what he likes to say is, think of LMs as autocomplete on steroids, right? So, when you type in words, for example, in this instance, coronary artery, how does Google know what the next most common word searches, right? The reason it knows is that they take a lot of data from other similar searches, and they can assign probability or statistics, right? To say, all right, is it the most common is probably if someone is looking for coronary artery, the next most common is coronary artery disease, right? And then the next most common is maybe coronary artery disease symptoms, so on and so forth. And I just wanted to point out something, right? So on the left, you can see sort of this very nice Google graphic saying that actually a lot of these are still quite new emerging capabilities. Everything from healthcare to writing a nice haiku or poem to drafting something in the style of a rapper, for example, right? A lot of these discoveries, even for researchers like myself, are still ongoing. And to point out how some of these things can be quite surprising, right? If you look, I do sometimes receive interesting messages, and I think this was one on the social media platform from Joe Weber, who is the inventor of autocomplete, right? One of the earlier technologies. And he said, all right, I was one of the inventors of these technologies. And even now I'm still gobsmackingly impressed of how, they are able to come up with these responses. I don't have a clue, right? I think that's to speak to the fact that a lot of these technologies in terms of the capabilities are still evolving, and we still don't fully grasp all of them, which is why a lot of this performance indexing is so critical and important. And so moving on, I mentioned early on in 2022, we decided to start looking at how doctors using AI tools would perform. I think this was one of the inspirations, right? In 2022, there were all the studies coming out that said, all right, GPT 3.5 scored 60% on the US MLE. So for those who are unaware, the US MLE exam is an exam that all medical school students, residents have to take to become fully qualified, right? So maybe if you were to look at the score back then, all right, 60%, interesting, right? But no one really wants to see a doctor who's barely passing. I think just to give you a sense of how the performance was back then. And then looking to 2024, all right, suddenly, it's scoring 86%. And if you actually indexed it now, it's literally off the charts, right? And this is just talking about open models with minimal fine-tuning, training, and a lot of other techniques you can do to improve these models. So as you can see, obviously, from the direct, going to the roof, it's improving very, very extremely fast. But I think a fair critique then as well, oops, how do I go back one? Is doctors don't do MCQs, right? Going back to the question of how do we even compare indexes of performance, right? I think a fair pushback by a lot of medical journal editors, physicians is, all right, these exams are good, but they're kind of a plaything, right? You don't go to see a doctor and present a list of A, B, C, D and tell a doctor, pick one, right? Which diagnosis, which treatment you want me to do for you. I'm going to talk about the meaning next, right? Because I think it's important for everyone here to have some degree of, some basis of understanding, right? Whenever there's a headline like this, how are the studies conducted? What are we actually measuring? Why are we measuring? So the New York Times headline actually was based on one of our earlier studies. It was a small CT, about 50 physicians. I'll go a little more into that. But why it actually captured so much imagination in headlines was because, surprisingly, even for us, we actually discovered that the AI alone did better on this simulated series of cases. As you can see, it got 90%, right? And doctors without AI got 74%. And even doctors using AI still didn't do very much better than the AI alone. So obviously that was quite surprising, and we didn't expect that. But just to give you an illustration of how quirky reporting can be, right? I think it was 2 a.m. I was in Tokyo. The same day the New York Times article got published, I got a phone call from Washington Post, right? Asking me about this study because I thought she found it really interesting as well. But I think the headline, as you can see, is still accurate, but it's not quite the message that New York Times went with, even though I told her exactly the same thing, right? And in this instance, her read of it was that ChatGPT, and it's still correct, by the way, right? If you look at the graph, ChatGPT is little help for doctors in diagnosing disease, studies fine. Saying this because I thought it was an interesting way to show how journalists tend to report on what they find the most interesting for their story. Okay, so I'm going to go briefly into what we actually did for this study. So it gives you some sense of what the participants actually went through. So as you can see here, I said earlier on that multiple choice questions are not quite representative of what a doctor actually does in day-to-day care, right? So what we actually did in this instance was that we used a series of real clinical vignettes and open-ended questions, not unlike what a medical school student would do about year 3 or year 4, where he starts moving away from USMLE multiple choice questions to maybe more using patient actors, going into a room with maybe someone like Dr. Chandra, assessing him and asking him this sort of open-ended questions, right? So in this example, it could look something like this, 72-year-old man, hypertension, smoking, telling him the past medical history, and a simple open-ended question like this, right? Instead of multiple choice questions, you're just asking, and a medical student has to answer. What are the 3 most likely diagnoses for this patient's primary complaint of shortness of breath? So it's not constrained anymore, right? It's not, hey, chatbot, human, pick one of the 4 best answers. Obviously, by chance, it's a lot higher. Suddenly, because of the open-ended nature, as well as the open-ended grading rubric, right? What that really means is that because it's a free text response, how does a human grader then assign scores to a free text response as well? And so you can see it's not didactic. There's some rubric grading guidelines. So a lot of the work really goes into designing really customized, meaningful rubrics, right? That a bunch of experts would agree is fair to score this rubric on. So we had attending doctors basically scoring all the students. And as I mentioned, it's suggestive. It's not at all exhaustive. As you can see here, right, first of all, how did GPT 3.5, and I know now we're on GPT 5 already, but back then, how did 3.5 do? Okay, got 70%, which is not bad, considered passing score for medical students, a lot who are at Stanford taking this study. And how did GPT 4 do? Suddenly, paralleling the earlier graph I showed you, right? It was really doing a lot better, somewhere in the order of 87, almost 90%, and it was already defeating medical students. I think this was sometime 2022 when we did the study. And so the next thing becomes, all right, these are medical students, right? So they don't form a very, very fair basis. And quickly to jump into the question 1, right? Why are we even comparing, doctors versus AI? One of the ways of thinking is that it gives us a basis for comparison, because if we tell AI is this harmful, right? As humans, we don't have a mental model on what we are comparing against, right? Whereas if we can tell you that a doctor today who is trained and qualified is doing to this performance, that becomes a lot easier to understand the trade-offs. And that's really why you're seeing all these headlines and studies that are comparing both. I know we're running a bit low on time, so I'm just going to go through quickly the next study and what we did. So earlier on, we did medical students. This one was attendings, right? I think, again, a pushback going from multiple choice, open-ended questions to medical students, attendings. So once again, and this was a study this year published in Nature Medicine. We repeated the study, this time with real cases. We fed information bit by bit to simulate a more realistic case. And this time we had trained attending physicians from Stanford, Harvard, Virginia, Minnesota. Almost 100 doctors do this similar study design. Once again, rubrics, open-ended questions. As you can see, they are super complex, right? This vignette was basically about a patient, elderly, post-surgery, had a fall, abnormal heart rhythms. Do you want to start blood thinning medications? I'm going through all this just to give you a sense of how complex it is. But as you can see, I think this was, again, a surprising result. GPT-4 alone did way better, even than doctors, well, similar to doctors using AI in this instance, but a lot better than doctors using whatever they are using today. And again, this is a huge jump again, right, with this newer reasoning models. This latest paper on the right is undergoing peer review right now. But as you can see, again, with the reasoning models, right, again, significant performance gains. And I don't see this topping out anytime soon. So this graph was really to say, we had a lot of obviously existential, right? Physicians coming to us, all right, crap, now our job is in jeopardy. And there, one view of thought is that, okay, but doctors, humans, right, we're a lot more empathetic. And I think that there were two studies that were both simulated, right? Basically, a Google study and a sort of JAMA study using Reddit doctor forum question answers, right? Basically letting patients pick. Do you prefer the AI response or do you prefer the sort of doctor response? And almost overwhelmingly, the human respondees prefer the AI chatbot response. And if you think about why, it's because doctors have 5 to 10 limits, right? Like, hell, we are also constrained by resources. I simply don't have the time to type out a very, very long and detailed response. And I think with a last clip in here, I just wanted to show you, I think—
Hi, I've been feeling really—
Oops. Okay, I'm just going to play a short clip. I'm sure some of you might have seen this AI doctor, not AI doctor, sorry. You might have seen these videos where they are generated purely by Google Veil. And it looks super impressive, right? I've seen videos where someone is basically doing a sort of selfie journal and recording, sort of a Star Wars character, so on and so forth. So I thought, all right, this looks easy. Let me try that. And I was just trying to imagine what, to me, an AI doctor would look like. And for me, how I think this starts is that it's probably going to act at the level of maybe a medical resident, and maybe the patient would walk into the room, interact with this AI chatbot. And I basically got Veil, to write a brief prompt and basically generate it for me. Let's see how it did, because this, to me, it's a bit fun.
Tired lately.
Okay, I see. Let's talk about the plan.
Okay, so maybe you didn't grasp all of it, but there were a lot of flaws in that brief 10 seconds clip, right? People walking through the walls, the wrong audio clip set to the wrong person, so on and so forth. So
Hi.
let's go to the next one. And we are at time, so this is probably the last slide, and I'll wrap up with thoughts. But I thought, all right, maybe I'm not doing it the right way. Why not use an AI to write a prompt for an AI, right? Like, I said, hey, this is a smart thing to do. So I was very impressed with the prompt they did. They did it Hollywood style. There was an act scene, soft lighting, video camera, and all of that. So I took that prompt, I pasted it in again, and let's see how it did this time, whether it did any better.
Michael Smith.
Michael Smith. Hello, how can I help you today? All right, Michael, let's talk about what the AI has put together.
You can see what happened there, right? Once again, it didn't quite get that I wanted to have an AI doctor resident follow the script throughout, right? Patient interact. It was assigning the script to all different people. So I was like, all right, maybe the third time's a charm. So let's try again. Oops, reached my limit, right? Oh, you didn't see the last slide. I reached the limit. So actually, Veil stops you, I think, after you use too many credits, because these are still quite computationally intense. And I think I use this to demonstrate that even though, lots of these AI technologies are improving quite fast, there are still a lot of nuances and limitations, right, around the parameters. All to say, AI doctor is a really interesting concept, not anytime soon. For the moment, there are going to be a lot of guardrails and more science needed. Thank you.
Good afternoon, everybody. For a moment, I thought that he was actually going to ask me that question. I was like, hey, where's my ChatGPT? So I'm Saurabh. I'm the Chief Telehealth Officer at the Center for Telehealth at University of Mississippi Medical Center. Okay, so I'm not used to speaking in the mic, so but you can tell me if you're not able to hear me. So I am the Chief Telehealth Officer at University of Mississippi Medical Center, and so we have been having a great time today listening to these two talks. It will be a difficult act for me to follow. But what I bring today is a little bit of a different flavor. And what I want to start with is, I want to talk about our journey and our foray into AI, and why did we embark on this journey, and why did we thought about AI in the first place. So before I do that, I have no conflicts to report. And I'm going to talk about how we are going to integrate some of the AI into telehealth workflows. Come back to that. But wanted to talk about Mississippi and our Center for Telehealth. Our Center for Telehealth actually provides services to a broad coverage area in Mississippi. We have a vast footprint, and we have 20+ projects that we have implemented in Mississippi as well as outside Mississippi. And this has been our journey. We have been leaders in telehealth for the more than last 2 decades. And as Sylvia mentioned, we are one of the 2 centers of excellence for telehealth designated by federal agency HRSA. And what I wanted to point out is that, so we have been awarded a lot of these grants and designation by HRSA, but what I wanted to point out is in 2020, last week, we had our name change from Center for Telehealth to Center for Telehealth and Emerging Technologies, because we want to embrace AI and other technologies like digital platforms and see how those can, intersect with telehealth workflows to enhance the value that we are bringing through telehealth. It's very important for you to understand, why did we embrace it? And I have to go back to the COVID era that everyone is trying to forget. So in 2020, we all know that health services pivoted overnight towards telehealth to provide services, to keep the services running for delivering healthcare. Come 2022, COVID was dissipating. And when we were looking at our data, we were looking at, well, there was a huge uptick in, utilization of telehealth that was then declining, coming down. And we thought that let's ask some questions. So let's ask the questions of the clinicians as to why, why there's a decline in the utilization of telehealth. And what we heard from them was that during the COVID era, there was basically no other alternative. Everybody has to pivot. But they felt that, we don't have enough time during these visits to glean all the clinical information that they need to have to make important decisions regarding patients' diagnosis and treatment and management. And so we thought, okay, how can we increase the time? How can we increase, give more time for patients to be engaged? Because engaging patients in person is a challenge. Trying to engage them and get all the clinically relevant information through telehealth audio visit adds a level of complexity. So we thought, how can we do that? So that was one thing. Then the other thing, what happened during COVID, and I think most of you must be aware of it, and I think Jordan had mentioned in his first slide, was workforce shortage. So especially for the nursing staff, there was a rapid turnover of nursing staff. There was a huge burnout, not only for providers, but also for nursing staff, leading to severe nursing shortages, which had domino effect on hospitals not able to provide those services, keep their services running, leading to hospitals being at risk of closure, especially in rural areas. So we thought that what can we do to improve, alleviate this nursing shortage? So I'm going to talk about these 2 programs here, how we are embarked on our journey by first understanding what need is out there and what need is we are trying to bridge. So first I'm going to talk about our AI Scribe program. I think we all know about provider burnout. I've talked to you about provider engagement and patient engagement and lack of it in the audio during the telehealth encounters. So we decided there's a lot of data out there. There's a data out there, some good studies out there showing that AI Scribe works, but they have not been focusing or those studies have not focused on on telehealth and how AI Scribe can be used for telehealth. It's a different thing to have software and when both the patient and the provider are sitting in the same room. And it's an entirely different thing for using an AI Scribe where you are geographically located in different areas. So that was a reason we started on, you put a project together. I'm going to skip some of these. I think there are a lot of technical people out there who already know what AI Scribe does. It uses, large language, natural language processing and other modules to actually convert voice to text. So I'm not going to show this and go through this. So we brought in a number of providers from different specialties. And when I talk about specialties, I'm talking about specialties that actually take a long time in engaging patients and long documentation time. I'm talking about psychiatry. I'm talking about geriatrics. So we engaged some of these providers, understood their challenges, understood what is called the pajama time, how much time they are actually having to put in after the offices are closed from home and trying to, catch up on their documentation and bring up a documentation good enough that they don't get called from the revenue cycle to say, hey, go back and make changes on your documentation. So we selected these providers who were facing challenges. We've a workflow. We actually investigated and explored a lot of vendors and selected a vendor and embarked on this study. And what we are going to show you is our results. And one of the things that we do is that we want to create and contribute to evidence. So all these studies have, IRB behind them. And so this is an observational study, and I'm going to show you some of the results that we have. So this was, we undertook a survey before and after the implementation of our project, and we showed that there's a trend in higher provider satisfaction with time spent on documentation. So they were reducing the time that was spent on documentation. There was trend towards higher provider satisfaction with the quality of the AI Scribe, and higher trends towards they felt that they were spending more, having more engagement with their patients. So I've been shown that, I've been told that there are only 5 minutes left. So I'm going to skip some of my presentation here and move to the next part, which is actually how, and this is really cool. This is really cool because we are trying to enhance our virtual nursing workflows, which already have demonstration great value by bringing in AI. And what we are doing, what is cool about it is that what we are doing at a health system or academic medical center, simultaneously, we are doing this study in a small critical access hospital with 25 beds, which have a totally different resources available to them to implement AI workflow. And we can talk a little bit about some of the challenges that we face there. But I'm going to talk about our how we enhanced our virtual nursing workflow in the last 2 minutes that I have. So we undertook a pilot program. We put hardware, software to acquire computer vision and see how, and train on how to, and our objective was to prevent patients from falling. So the virtual nursing was already there. They were doing admissions, discharges, patient rounding. The AI component was trying to prevent falls. I'm going to skip all of that. I've been shown the timer again. So what the AI does, the AI actually creates alerts for telesitters. And what they're trying to do is they're trying to capture the movement. They're trying to predict whether the patient is at risk of falling. And based on the movements of the patient, based on the training model, they can say, hey, the alert could be green, caution, or red. If there's a red, then the telesitter goes in and talks to the patient, if they feel like the patient is still not, still there's a high risk of falling, they bring in the bedside nurse. I'm going to skip this and talk about my data. So what this data show is how many times the patients were redirected by the virtual staff and how many times they asked the bedside to come and intervene. So it was the program was implemented in February, still continuing in July. So far, redirection is more than 2,000 times they have redirected the patients. And the staff have to intervene around 800 times. They had called in the staff to come in and intervene at the bedside. There have been some falls. Most of these falls were when the bedside nurse was there, so there was nothing much that the virtual nurse can do. But here's the data that is most interesting. Comparing 5 months of data prior to implementation, 5 months after the implementation, there has been a 28% reduction in the number of falls, but more importantly, 67% reduction of falls with harms that we have achieved. So those are our two programs that I wanted to highlight. I also wanted to highlight this, and this is our the employee engagement where we have implemented the virtual nursing program. The virtual nursing program has, the unit that has the virtual nursing program has one of the highest employee engagement in the entire institution. So when we talk about cost, when we talk about who's going to pay for AI, the question that we need to answer moving forward is, can this be just the standard of care that is important for benefiting the patients and actually making sure that your providers, increasing their well-being? So I'm going to stop there. I've been told that I have to stop here and happy to take any questions. Thank you.
There are many questions coming in, but I will pick and choose. What low, reasonable cost solutions exist to keep patient data safe while allowing a small critical access hospital to unlock the power of AI?
Sorry, can you repeat the question again?
Of course. What low/reasonable cost solutions exist to keep patient data safe while allowing a small critical access hospital to unlock the power of AI utilization?
So I don't think there are any that are existing right now. The solutions, the program that was implemented and supported through a grant, and that we are looking into that. But to answer the second question about how critical access hospitals can unlock the power of AI, what I'm going to say, and so when you talk about when we implemented this program at our main academic medical center, there's a telesitter around the clock that is viewing this data. When we go to the small critical access hospital, they cannot afford around the clock telesitter for a 25-bedded hospital. So what we were able to achieve, and this is really remarkable, we were able to convince the nursing staff to actually keep an eye on the monitor in addition to what the job that they are actually doing. And I'm happy to point out that the value that the program brought for the nurses and the care that they are providing and showing the improved outcomes had them embrace that and create this as a part of their workflow. So what I'm trying to point out is that critical access hospital, rural hospitals may not have the resources, but they can be innovative and creative in how to come up with solutions that do not cost a whole lot.
Should we do one more? All right. Is equipment readiness a barrier to implement AI into clinical workflow, or can you get by with already existing equipment?
Equipment, you have to have a totally different set of equipment for AI, and there are costs attached to it. You have to look into whether they are going to be integrated to the Epic or your EMR. So yeah, I mean, all these AI solutions have expensive equipment behind that. I mean,
Yeah, I think what Dr. Chandra said, I think not just the question is asking more about hardware equipment, but most of the costs are to do with things like software and people expertise, meaning to say it's more data infrastructure. And then afterwards, it's then becomes a question of what's a use case, how do you protect the data? Do you want to go for local model that we can do on-prem, which means buying costly, expensive servers, or more pragmatically, usually what health systems would do is set up some secure way to access LLM API. So for example, at Stanford, we have something called Secure GPT that allows us researchers, as well as operational folks, as well as clinicians, to access large language models and put in PHI. And then you can obviously also build on top of that. But I think that's how I would think about, the new sort of investment in infrastructure, primarily around people as well as the data infrastructure.
I think we'll do one more. All right, so bear with me. AI systems are built on several frameworks that are dependent on large tech ecosystems that could be unreliable, prone to attacks, and have bugs which could cause medical errors and hurt human lives. While tech companies on the effectiveness of their products for sales, shouldn't the user or the doctor be available for liability and responsibility for the patient? Furthermore, the effectiveness of prompt engineering would determine the response given by AI. Who validates this response? Another AI or human discretion? That's a big one.
I'm happy to go first. So the short answer is you always need human experts to validate the AI outputs, right? So whether you look at big tech companies, research setups like Arise, Arise Network. Network refers to actually a lot of human physicians, academics, right, to come and design and validate all these outputs. Because the other way just doesn't work, right? I've had tech, engineers come to me and, all right, I use an LLM as a judge, right? For those who are unaware, LLM as a judge is when you tell like what I did, right? Using LLM to create a prompt, right? Seems smart. Use an LLM to say, hey, can you grade in a way of a human doctor or this course? It works to some degree, but there's a lot of nuances and a reality to one part of the question, because there was a multifaceted question. The one part to that is that you always need human experts to validate the AI outputs. I think, what was the earlier part? Lulu, could you repeat the earlier part of the question, please?
Earlier part of the question. Let me get right to it.
Oh, it was liability. I feel like there will probably be, I think one part was liability, right? I feel like Sylvia would have a
Yeah,
good discussion then. Was there a
yeah.
third part in there besides liability?
They said, furthermore, the effectiveness of prompt engineering would determine the response given by AI. Who validates this response? Is it another AI or human discretion?
Right. So I would say always start from the final output, right? Because prompt engineering is just one facet. As you could see, my prompt wasn't great, clearly, but there were other parts that were causing the demo I showed on the video, right, to break as well. So you should always start from the use case and how to think about the grading and how to get an expert to come in, even if it's just one person doing a vibe check, right? It could be a pharmacist for selecting right drugs to do a vibe check, review the outputs. Or in our case, we use a lot of clinicians because the product and use case was a lot more of clinical decision support. So that's where I would start. Don't fixate on just one thing, prompt engineering, because yes, that can go wrong, but a lot of other things could go wrong as well, not least because they are releasing models so fast, right? And so the failure modes tend to change as well. For example, just to illustrate, to make it more real, I think with the last GPT 4.5, there was a lot of syncophancy, meaning they'll reconfirm, right, what you're saying. As GPT-5 tried to address that, but open up other types of issues. Don't know if Dr. Chandra, you want to add on anything? Yeah.
Okay, Dr. Chandra, just one last thing I'd like to call out. Would you like to share with folks some information about some exciting developments from the Center of Excellence and forthcoming possible tools?
well, as I said, we are trying to solve problems for a rural and underserved population. And I think Jordan mentioned most of them that are applicable. We are in Mississippi, 54% of our population are living in rural areas. We have almost the lowest patient to provider to patient ratio in the entire country. So shortage of providers. And on top of that, one of the highest chronic disease burden in the country. And add to that the travel distance that patients have to travel to seek care. So one of the most exciting for me, and I think there are many other medical centers who are exploring this as well, is how to provide access to specialists. In my part of the world, it may take several months to be able to see those patients via in person, and also many times scheduling and lack of connectivity, broadband access, prohibits audio visits as well. That also depends on digital savviness on part of the patient. So the most exciting thing in my mind that we are taking a look at it is how we can have provider to provider consults, how we can get primary care providers to ask questions of specialists using technology and using actually AI. And we are looking in how, because now what happens right now is primary care provider doesn't have too much time in the office. And if they have to send a question and we ask like, okay, can you give me more information? They're going to send you 50 documents. And then it becomes prohibitive on the part of the specialist to rapidly go and spend time and come up with an answer. So we are trying to use AI and large language model to actually enable that, where the providers can actually send that information to us and we can give a summary tailored to every specialty. For example, the cardiology, we give them a summary based on the 50 documents. You can read them and provide a concise summary. And I hope that can transform the way we can provide access to specialists in medically underserved areas, and probably can serve as a paradigm for similar medically underserved areas in the country.
Great, thank you both. These was a wonderful presentation.